Hello medicos, today we are going to see about long QT syndrome. Long QT syndrome is of two types, one is acquired, another one is congenital. In acquired, we will see a prolongation of QT interval associated with Torsades D pointes. Torsades D pointes means twisting of points. See in this ECG, it's like twisting of points, so it is known as Torsades D pointes. Prolongation of QT interval may be due to hypokalemia, hypomagnesemia, bradycardia, and drugs that will prolong QT interval. Let's see the cardiac action potential. There are 4 phases: 0, 1, 2, 3, 4, 5 phases. The first phase, 0 phase, is due to the sodium current. Phase 1 is due to the outward transient potassium current, that is outward transient potassium current, and phase 2 plateau phase is due to the three currents. One is current due to L type of calcium channel, another one is late sodium current, and at last the end of the plateau phase there is a potassium current which is slow component of delayed rectifier potassium channel. This current is also present in the early part of phase 3, and in phase 3 there is another two currents. One is the rapid component of delayed rectifier potassium channel, another one is IK1, which is inward transient potassium current. See, due to QT interval prolongation, when action potential duration is prolonged, there is QT interval prolongation. There are two types of after depolarization. One is early after depolarization, another one is delayed after depolarization. Early after depolarization can be seen during bradycardia or during action potential duration prolongation, when it can be due to potassium channel blockade. So when there is potassium channel blockade, there is more accumulation of positive ions within the cells, and the membrane potential will be oscillating. When the oscillation of the membrane potential is sufficiently high, there will be a depolarization. It is known as early after depolarization. It will be seen in phase 2 and phase 3. When there is net inward current, these depolarizations are produced. Okay, now let's see how hypokalemia and hypomagnesemia will prolong QT interval. Hypokalemia, this is a myocardial cell, and there is decreased potassium outside the cell, hypokalemia, and increased potassium, there is more potassium inside the cell. What we will actually think is potassium will move outside the cell rapidly because of the concentration gradient, and there will be rapid repolarization, and the action potential duration will be shortened. But actually what happens is the potassium has a paradoxical effect. It will inhibit the potassium current, especially the delayed rectifier potassium current, which has a rapid component of delayed rectifier potassium current is inhibited by this hypokalemia. So there is action potential duration prolongation. Hypomagnesemia is not seen separately, like isolated hypomagnesemia is not seen. It is always associated with other electrolyte imbalance like hypokalemia. Hypomagnesemia causing QT interval prolongation. Till today, there is no clear mechanism about how QT interval is prolonged by hypomagnesemia. Some of the studies say that hypomagnesemia causes hypokalemia, due to that there is action potential duration prolongation. Some studies say that magnesium is normally a inhibitor of L type of calcium channels. So when there is hypomagnesemia, there is decreased inhibition of L type of calcium channels. So during phase 2, we saw that the current is due to the calcium channels, L type of calcium channels. So there is increased calcium current leading to action potential duration prolongation. And magnesium will normally inhibit ROMK channels in renal tubular cells. ROMKs, renal outer medullary potassium channels. Now, when there is hypomagnesemia, the decreased magnesium will not be able to inhibit this ROMK, so there is increased K plus loss from the body. So, this is how magnesium causes hypokalemia. Okay. Now, let's see about ECG. See here, there is a sinus beat, then there is premature ventricular contraction, again there is a sinus beat. The first sinus beat and premature ventricular contraction have short RR interval. And long RR interval is seen, and there is another one short RR interval. During this long RR interval is due to the compensatory pause. Now, what is this compensatory pause? See, there is a premature ventricular contraction. So, because of this premature ventricular contraction, the next stimulus, which is a normal stimulus, will not be able to excite, and there is no contraction because the normal stimulus now falls in the refractory period of this premature ventricular contraction. So, there is a pause known as compensatory pause. Then we will see a normal sinus beat. This normal sinus beat will have QT prolongation. And then here you can see initiating beat of polymorphic ventricular tachycardia. It is present on the T wave of the normal sinus beat. So it is known as R on T phenomenon. Now this polymorphic ventricular tachycardia, name itself says it is multiple morphologies there. The morphology of QRS complexes are different. Okay, now let's come to pseudo 2:1 AV block. In neonates having long QT syndrome will have bradycardia and they will have pseudo 2:1 AV block. See this ECG, there is 2 P waves everywhere for one QRS complex. So what we will think, it will be 2:1 AV block, but actually there is no AV block. Why? See, the ventricles are extremely refractory so that the stimulus is not able to excite the ventricle and cause contraction. So there is 2 P waves, but there is only one QRS complex. So there is no AV block. So it is called as pseudo 2:1 AV block. We saw here due to the compensatory pause, there is polymorphic ventricular tachycardia. So it is known as pause dependent. A short, long and short RR interval, see here, short, long, short RR interval will lead to the Torsades depolarization. Now let's see about the action potentials of different ventricular layers, epicardium and myocardium. This is epicardial action potential, this is mid myocardial M cell action potential. See, I have drawn this action potential duration of mid myocardial cells is prolonged, but epicardial cells remain same. How? See, there is a term called repolarization reserve. If one of the potassium channels is blocked, see here, there are multiple potassium channels. If any one of the potassium channels is blocked, the rest of the potassium channels will work more and will compensate for the loss of that channel. It is seen in case of epicardial and endocardial cells, but myocardial cells usually have very less slow component of delayed rectifying potassium current, and IKAS, which is Happerman sensitive, small conductance, calcium activated, potassium current. See, because the myocardial M cells already have a less potassium current, and if one of the potassium current is blocked, there will be no compensatory mechanisms to uh, to prevent the prolongation of action potential duration. So the action potential duration is prolonged in myocardial M cells but not in epicardial cells. So see here, there is dispersion of refractoriness. See, because of this dispersion of refractoriness, it can lead to reentry circuits. Because of the dispersion of refractoriness, there is reentry circuit. See, there is prolongation of QT interval, prolongation of action potential duration, due to which early action depolarization is there, and due to increased dispersion of repolarization and refractoriness, there is formation of reentry circuits. These two will lead to Torsades depointers. Here, this dispersion of repolarization and refractoriness will act as loading gun, and this early after depolarization will act like pulling a trigger. So there is production of Torsades depointers. Clinical presentation, there will be syncope, and in some cases you will see that first clinical presentation would be a sudden cardiac death. How to treat this? We can treat it with magnesium sulfate, 1 to 2 gram IV. We can also give isoproterenol, which is non-selective beta agonist, and we can do cardiac pacing. It will suppress premature ventricular contraction. See here, due to hypomagnesemia, we are giving magnesium sulfate. When there is bradycardia, by giving isoproterenol, it is a non-selective beta agonist, so there is increased heart rate. We will terminate Torsades depointers, and by also cardiac pacing. Let's come to congenital long QT syndrome. See, congenital long QT syndrome can have many mutations. Till today, there are 15 mutations. The most prevalent ones are only 3 types. The mutations in the genes coding for cardiac ion channels. Long QT syndrome 1 is due to the decreased slow component of delayed rectifier potassium current due to the loss of function mutation in KCNQ1 gene, which codes for pore forming protein. It codes for the pore forming protein of the potassium channel. So there is loss of function, says there is decreased potassium current. And then long QT syndrome 2 is due to the rapid component of delayed rectifier potassium channel. There is loss of function in same like the long QT syndrome 1. Here the mutation is KCNH2 gene. It is also pore forming protein. Then long QT syndrome 3 is due to the increased sodium current. SCN5A gene mutation. This is gain of function. See, here during plateau phase there is late sodium current which contributes. So because of increased sodium current, there will be prolongation of plateau phase and there will be prolongation of action potential duration. Long QT syndrome 1 can be seen during exertion, especially during swimming. And long QT syndrome 2 is seen during emotions and when there is loud noise, auditory stimulus. Long QT syndrome 3 is seen during sleep. The QTC is greater than 440 in men and 460 in women. When it is more than 500 milliseconds, sorry, I didn't mention milliseconds, it will, when it is greater than 500 milliseconds, there is high risk of Torsades D pointers. Now let's come to the ECG of the Torsades D pointers. The type 1 will have a broad T wave. See, everything is long QT syndrome, so everything will have long QT interval. The one thing to notice is change in the T wave. There is broad T wave in type 1. In type 2, you will have a bifid T wave. In type 3, you will have long ST segment and then you will have long ST segment and a pointed T wave. Long ST segment, T wave is occurring late and it will have pointed T wave. Okay, now let's come to the treatment. Long QT syndrome 1 and 2 are treated with beta blockers like nadolol, propranolol. Nadolol 1 mg per kg per day. Okay. Long QT syndrome 3 can be treated with mexiletine. Why mexiletine? See, the current is due to the sodium current. Mexiletine class 1 B antiarrhythmic. It will inhibit late sodium current. So, due to the inhibition of late sodium current, it will decrease the prolongation of action potential duration. So, it can be useful in long QT syndrome 3. Thank you.